member faculty of radiological sciences and medical imaging at Al-Zaim Al-Azhari University, Khartoum, Sudan. He is Dean of Faculty of Graduate Studies and also working as external examiner with many universities like Johannesburg, University of Durban, which is in South Africa, then Sudan University of Science and Technology, Khartoum, National Ribat University, which is of police, Karare University, Sudan, and he is consultant for curriculum design for Gulf Medical University, UAE. He is also facilitator and organizer for live streaming courses with International Society of Ultrasound in Obstetrics and Gynae, which is UK based. I would like to request Professor Dr. Ahmed Abdul Rahim to start his presentation on first trimester ultrasound of normal pregnancy. We will apologize from many of the participants because the capacity we have is of 100 participants, although at the moment we have 31, but with us, the registered participants are above 275. So we will be able to take 100 here, and you can advise your friends, the remaining people who are registered, they can go to the live streaming at Facebook. They can write their names and emails so that we can send them participation certificate. So Professor Dr. Ahmed Abdul Rahim, the mic is with you. Kindly start.
Thank you very much, Professor Jailani. Bismillah, alhamdulillah, salatu wassalam ala rasulillah. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Today topic is first trimester ultrasound of normal pregnancy. The mean duration of their pregnancy is 40 weeks based on menstrual dating, with the first day, the last menstrual period, LMB, presenting the clinical reference point. Each trimester of pregnancy is technically 13.3 weeks or 13 weeks. They rounded off of tens about, and many authors refer the first trimester as 12 weeks or 14 weeks. First technique, usually we use TVS and transabdominal ultrasound. Transabdominal ultrasound, we use it in second and third trimester, and we use transvaginal ultrasound effectively in this first trimester of pregnancy. So first trimester ultrasound indication, the most common indication are vaginal bleeding, maybe threatened abortion, suspected ectopic pregnancy, lower abdominal pelvic pain, palpable pelvic mass, uterine size, dates, discrepancy. An ultrasound has the following emergency clinical question to answer. We should answer where is the pregnancy localized. Is it intrauterine or ectopic pregnancy? Wherever the ectopic pregnancy is. Is the embryo or fetus alive? We should answer this question also. What is the probability of consequent demise of living embryo or fetus? And the other goal of first trimester sonography are estimation of gestational age by taking different measurements. So assessment of multiple pregnancy, evaluation of nuchal thickening, nuchal translucency, nasal bone, and also screening at 14 weeks for congenital abnormalities. Let us to start early, from weeks 1 and 2. We start with first phase of the cycle, week 1. The length of the average menstrual cycle is 28 days, as you know. And the first menstrual day is designated as day 1 of the cycle. So the menses usually last about 4 to 5 days. And after menstruation, the eroded endometrium is seen. So it is less than 4 mm in which, so this is the ministerial phase. Endometrium is very thin. So echogenic line is the center of the uterus. Here is the fundus of the uterus, body, cervix, and here is endometrium. This is just after menstruation. Endometrium is very thin. Then after that, the proliferative phase, and this phase lasts about 9 days. It starts from the last day of the bleeding. So during these 9 days, means from day 5 to day 14, FSH acts on the primary follicle until it becomes mature ovarian follicle or Graafian follicle. Here is so early in the cycle phase, we have small immature follicles. Then when follicle grows and becomes dominant follicle due to effect of FSH on the ovary, and on ultrasound it looks like this. So thin smooth wall, echo-free, rounded shape follicle on the periphery of the ovary, reaching about 2.5 centimeter in diameter, which is Graafian follicle. This follicle is ready for ovulation by ultrasound. This is TVS image, so representing Graafian follicle or dominant follicle. After that, the ovulation at day 14 of menstrual cycle, the ovulation is triggered by the surge of LH production. The excipital secondary oocyte goes to the tube, and the follicular wall is then transformed into a glandular structure, which is corpus luteum. Here is the corpus luteum, which is thick irregular wall, and also there is internal echoes due to hemorrhage. This is after ovulation, which occur in day 14. Here are the different phases. Now we are here at the 14th day of ovulation, and endometrium becomes sick. So what about endometrium? After menstruation, the endometrium is demonstrated as single echogenic line, and the estrogen biosynthesis by the dominant follicle lead to stimulation of endometrium with growth of glands and stroma, and the thickness of endometrium is increased. So this change is visualized as a triple line appearance, so like this. Endometrium becomes thick. Here on ultrasound, triple line appearance. This is the end and late proliferative phase around day 14. So thickness of endometrium at this time can reach 6 to 10 mm around the days of ovulation. If we measure the endometrium from here to here at these days, so it reaches about 6 to 10 mm. Then we move to week 3 to 4, these weeks of conceptus. So day 14 is ovulation, changing in the endometrium, becoming soft, thick, edematous in response to progesterone. Day 15 is day of fertilization. Here the dominant follicle or the egg, so comes here in the tube, and fertilization occur here. This on day 15. So day 18 morula stage or 16 cell stage. Here is morula, 16 cell, and this occur in day 18. Day 20 blastocyst stage enter uterine cavity. Here the blastocyst enter the endometrial cavity following conception, beginning of implantation. So blastocyst is a precursor to the gestational sacs in ultrasound, but is too small to be sonographically visualized as this stage of development. And day 23 implantation complete is the implantation completed in day 23-24. So day 27 to 28 formation of secondary yolk sac, which is here. And day 21 to day 28 proliferation of syncytial trophoblast formation of primary chorionic villi. So after the morula enters the uterus, 16 cell division at day 20 enters the uterus, and by end of day 23 or 24, complete implantation occur. Fluid passes through it to form the blastocyst cavity. Here is a blastocyst cavity. The fluid starts to enter this cavity. So the fluid continues to enter the cavity until the blastocyst is separated into two parts. So the trophoblast, this layer, and the inner cell mass. The inner cell mass is the future embryo. And the fluid start to fill or continue to fill this cavity. As the gestational sac, when the gestational sac appear in ultrasound, appear as fluid-filled structure, a small rounded structure. So trophoblasts start to proliferate rapidly, differentiated into two layers, which is cytotrophoblast and syncytial trophoblast outer layer. So here we have two layers, this layer and this layer. Also in this diagram, this layer and this layer, which is cytotrophoblast, and this is the inner cell mass, which form the future embryo. At the time of implantation, all these concepts about 0.1 mm. So trophoblasts serve as a source of nutrition for the rapidly developing blastocyst and also secrete HCG. An adequate amount of HCG is essential at this stage to maintain the activity of corpus luteum, or corpus luteum produce estrogen and progesterone, which also support the deciduo or the endometrium. So blastocyst embed completely in the functional layer of the second endometrium by about day 23-24. Here is endometrium. Here fertilization, then zygote formation, then 16 cell division, blastocyst and enter the uterus and embed here on ipsilateral wall, on the wall near to the ovulated ovary. So implanted in this layer, and by ultrasound, the endometrium will be very thick, well prepared for implantation. So implantation occur on ipsilateral wall of the ovulatory ovary. Here is fertilized egg diagram showing the fertilized egg, then 2 cell divisions, then 4 cells, then 8 cell divisions, then 16, then blastocyst, which enters the uterine cavity and completely implanted in the wall of the uterus by the end of day 23 or day 24. Again, completely implanted here, not in the center of the uterus, not in the cavity. If the blastocyst comes here, it will be go down. But the blastocyst implanted in the wall of the uterus, and at this time, when we may have a small blood spot, which representing the implantation. If transit of blastocyst has been delayed for any reason, so by day 20, the blastocyst will reach here in endometrial cavity. If delayed, the ectopic pregnancy will occur. Wherever tubal ectopic pregnancy will occur, which is abnormal. The normal sonographic appearance of early pregnancy. So can be divided into two categories: before visualization of gestational sac and after visualization of gestational sac. So we divide it into two categories. So one by one, sonographic appearance of early pregnancy. The gestational sac represents the chorionic sac and its contents, including the yolk sac, embryo, and the amnion. Here before sonographic detection of gestational sac, the endometrium is sick or the deciduo is sick, homogeneously sick. This is the endometrial cavity or uterine cavity, and here is the deciduo or endometrium, and also more prominent uterine vessels. And these changes are too subtle to be reliable. So warm uterus sign is increased uterine vascularity observed on transvaginal during early pregnancy. Here, if we put power Doppler, which is more sensitive, we can see more blood vessels supplying the endometrium. So this is before sonographic detection of gestational sac. This is before we see the gestational sac, the endometrium is sick, and also the uterus is warm with more blood vessels supplying the endometrium. Then, before sonographic detection of the yolk sac. So gestational sac is the first pregnancy structure that can be detected by ultrasound as small rounded cystic structure in the endometrium. At the fundal level, it is usually visualized from 4 weeks plus 5 days of gestation using transvaginal ultrasound, which is measure about 2 to 5 mm in diameter. And here how we measure the gestational sac. Here is the gestational sac. So it can be identified a week later by transabdominal ultrasound, because transvaginal ultrasound is more accurate and has high resolution compared with transabdominal ultrasound. So gestational sac is usually fundal, number one, and eccentrically just beneath the uterine cavity echo in the decidua. Here is the uterine cavity, this echogenic line, this is uterine cavity, and just beneath the cavity echo is the gestational sac, which is fundal and eccentrically because of implantation of blastocyst in the wall of the uterus, in the wall of endometrium, not in the center. So here we can differentiate between the true gestational sac and pseudo gestational sac. Here is true gestational sac, fundal and eccentric, and also here we have a small gestational sac. This is echogenic line is endometrial cavity, and eccentrically we see small gestational sac. So this finding is referred to as intradecidual sign and is a very reliable sign of an early intrauterine pregnancy. This is very reliable sonographic feature of intrauterine pregnancy. Then double decidual sac sign, DDSS, which describes the sonographic visualization of two distinct layers of decidua associated with a true intrauterine pregnancy. Also, this one of reliable sonographic feature to diagnose true gestational sac when the endometrium is differentiated in two layers, two distinct layers. This is very reliable feature, which is called double decidual sac sign. So it can be demonstrated at about the same time the yolk sac can be detected with transvaginal ultrasound. So it's helpful to distinguish between a true gestational sac and pseudo-gestational sac, which represent fluid in the endometrial cavity in the absence of an intrauterine pregnancy. Here is pseudo-gestational sac. Yes, there is fluid collection within the endometrial cavity located in the center in the endometrial cavity, and here is true gestational sac with double decidual sac sign, which is very reliable sonographic feature to differentiate between true gestational sac and pseudo gestational sac, which may be appear with ectopic pregnancy. Here is double decidual sac sign and true gestational sac. We have this diagram. This is the endometrial cavity appear on ultrasound as echogenic line, and here we have true gestational sac, which is eccentric and fundal. Here on sagittal and here on coronal, this is the endometrial cavity, which appear as echogenic line, and here we have true gestational sac. Here is pseudo gestational sac. Fluid fills the endometrial cavity in the center of the cavity. Here on sagittal and here on coronal, we can see here. So it is very important to differentiate between true gestational sac and pseudo gestational sac. So before sonographic detection of the yolk sac, the shape of the sac can be distorted by shape of this sac can be distorted by, for example, uterine contraction or by fibroid or full bladder when scanning by using transabdominal ultrasound or by pressure of distorted of gestational sac. This is true gestational sac, which is fundal and eccentric, also can be distorted if you have these structures. So gestational sac grows approximately 1 mm in diameter per day. Correlating serum beta HCG level and ultrasound finding for normal pregnancy. Here is exam type. If you have transvaginal sonography, level of beta HCG above which intrauterine pregnancy typically seen about 1,500 to 2,000. And if we are using transabdominal sonography, the level of beta HCG above which an intrauterine pregnancy typically seen about 6,500. And 1,000. As unexpected HCG values early in pregnancy, indicative of case of poor trophoblast or placental function, early failure or miscarriage, ectopic pregnancy also. So in these cases, we have lower than expected HCG values. And high values of HCG are associated with multiple pregnancy, gestational trophoblastic disease, or molar pregnancy. Then yolk sac. And yolk sac is the first structure in the gestational sac to be sonographically visualized. Here is the gestational sac. And inside the gestational sac, we have this small ring representing the yolk sac. By transvaginal sonography, by 5 to 5.5 weeks gestational age, when the mean sac diameter is 8 mm. Here also is yolk sac. This is the yolk sac. This is gestational sac, and here is the yolk sac. In transabdominal sonography, you can see yolk sac by 6-week gestation age when the mean sac diameter is 20 mm. Sac diameter is reaching 20 mm. We can see the yolk sac. So the yolk sac diameter increases steadily by 0.1 mm per day until 10 weeks gestational age to a max of 5 to 6 mm. So the normal sac diameter is up to 6 mm. So yolk sac is initial source of exchange between mother and embryo, and it provides nutrition, metabolic, endocrine, and immunological and hematopoietic functions. By ultrasound, the yolk sac appear as spherical in shape with well-defined echogenic rim. So here is well-defined echogenic rim internally, echo-free or sonolucent internally, reaching diameter up to 6 mm. So here is gestational sac, and inside we have the yolk sac. Here is endometrial cavity, and the gestational sac is eccentrically. Then, after that, visualization of embryo. So when we see the embryo and where we see embryo. By transvaginal sonography, we see embryo at 6 to 6.5 week LMB, and the embryo is initially seen as 1 to 2 mm cluster of amorphous echoes on the wall of the yolk sac or embryonic fetal pole. 6 to 6.5, where we see the embryo on the wall of the yolk sac, which gives the sign of diamond ring sign. Diamond ring sign. Here is embryo and here is the yolk sac. Again, here is diamond ring sign, here is the yolk sac, and on the wall of the yolk sac we have an embryo here, representing an embryo on the wall of the yolk sac. Again, here is the gestational sac, and here is yolk sac, and on the wall of the yolk sac we have embryo. Again, this is yolk sac, and here is embryo on the wall of the yolk sac. Here is the diagram representing showing the yolk sac is here, and here is fetal ball or embryo, and here is the amnion or amniotic membrane, so covering the embryo, and here is the amniotic cavity. So an embryonic heartbeat can usually be seen whenever there is an embryo. Whenever you see embryo, you should see the cardiac activity or heartbeat. Here is the yolk sac, and on the wall of the yolk sac we have embryo here. And whenever you see embryo, you should see the heartbeat. And also when the embryo measured 5 mm or more, and when the mean sac diameter is 16 or more, so greater by TVS or transvaginal sonography. Here, how to measure the heartbeats on M mode. So according to international guidelines, we should never use the pulse wave Doppler to calculate the heart rate or to see the heartbeats using Doppler. Just we can simply use B mode to measure the heartbeats and also to see the heart rate. Then double blip sign or visualization of embryo. Another sign, another sonographic sign to see the true pregnancy. So it's about 5.5 to 6 week gestation. The amnion may be transiently visualized as a faint curved linear echo with more distinct yolk sac and embryo. Here is the yolk sac, here is embryo, and here is the amnion. We can see the amniotic membrane covering the embryo. It gives the sonographic sign of double blip sign. Here is the yolk sac, and here is the amniotic cavity of the amniotic membrane, and in between we have a small echogenic structure representing the embryo and gives the sonographic sign of double blip sign. So this sonographic findings has been called the double blip sign, means the amnion plus yolk sac 2 blip, and in between we have fetal ball. So in this situation, the embryo is seen between the two cystic structure. Two cystic structure is the yolk sac and amniotic membrane. Here is double blip sign, yolk sac and amniotic and amnion, and the fetal ball is here. Again, double blip sign. So normal amnion appears as very thin circular membrane around the embryo. So here is the embryo, and here is amniotic membrane, and here is the yolk sac. And the yolk sac is intrachorionic extra amniotic. So the yolk sac located between the amnion and the chorion. So it is intrachorionic and extra amniotic. So here's amnion. If we are using very high frequency transvaginal probe, we can see the amnion very clear, the amniotic membrane very clear. So more information about yolk sac can be seen in the chorionic cavity from about 5 to 12 weeks of gestation. Here it is intrachorionic and extra amniotic. Here is yolk sac, here is amnion, is chorion. And after 10 weeks of LMB, is more difficult to visualize the yolk sac as it is compressed by expanding amnion and amniotic cavity. So the amniotic cavity start to expand and compress the yolk sac between the chorion and amnion. So after 10 weeks, so it is difficult to see the yolk sac because of expanding the amnion. Here again, in 13 weeks, almost the amnion and chorion to reach each other. So it is very difficult at this time to see the yolk sac. So after about 8 weeks LMB, the yolk sac or yolk stalk, this is the yolk stalk or vitelline ducts may be seen in the gestational sac as a separate cord-like structure connecting the yolk sac. This is yolk stalk, and also you can see cyst here in this stalk. Here by ultrasound, we can see yolk stalk or vitelline duct. Also, you can see abnormality here in the cyst. Here by 3D, and see the embryo, and this is the yolk sac, and this is the yolk stalk. And here by ultrasound, grayscale yolk sac, embryo, and in between we have this stalk representing the vitelline duct or yolk stalk. So absence of yolk sac or larger yolk sac associated with fetal demise or adverse fetal outcome. If you couldn't see the yolk sac, absence of yolk sac, or the yolk sac is larger, it means larger than 6 mm, this is associated with fetal adverse fetal outcome. So in general, a yolk sac diameter of greater than 5.6 mm before 10 weeks is likely to be associated with abnormal fetal outcome. Here is yolk sac. We measure the diameter of yolk sac, and also we see the wall of the yolk sac, and if there is any abnormality, maybe the yolk sac is absent or calcified or larger yolk sac. Also we mention and follow these cases. The visualization of embryo, the head and trunk of the embryo are not distinct until the embryo CRL is about 15 mm at about 7.5 to 8 weeks LMB. And if abnormal embryo is suspected and there is any doubt, follow-up scan is in second trimester between 16 and 19 weeks LMB is indicated. Here, trunk and head are not distinct until the embryo reach about 15 mm or 8 weeks. Normal upper and lower parts, here is upper limb spots, and here lower limb spots be seen as early as 8 weeks LMB. So head appears as to be considerably larger than the trunk and has a prominent posterior fossa or dorsal cyst referred to as the rhomboencephalon cyst or fourth ventricle. Here is the rhomboencephalon cyst, which appear in the brain as cystic structure, and head appear larger than the trunk. Here is the upper limb buds, and here is lower limb buds appear about 8 weeks gestation. Again, here is rhomboencephalon, which appear as cystic structure in the brain representing the fourth ventricles. Osteogenesis or mineralization or ossification of the bone is sonographically evident in the clavicle and mandible at about 8 weeks. Here is the clavicle, you can see clavicle early about 8 weeks, and by 11 to 12th week, the primary ossification centers, here is primary ossification centers of the long bones, scapula and ilia, as well as the limb articulation and phalanges can be identified by 11 to 12 week gestation. Then fetal stomach, here is fetal stomach, can be seen over 90% of fetuses by 12 week gestation. Here can see cross section in the abdomen. Here is the ribs, and aorta is here, then aortal vein is here, and here is the stomach filled with fluid. Also here, the fetal chest, fetal heart, fetal lung, and here is the diaphragm, hypocavic line. Here is the liver, fetal liver, and stomach is here, and then fetal bowel. So fetal kidneys, here is the kidney. This one is the kidney, fetal kidney. Can be demonstrated as early as 9 weeks gestation with transvaginal sonography, and the fetal bladder is seen in about 50% of fetuses by 12-week gestation. Here is the kidney, fetal kidney, and here is fetal bladder. Fetal bladder filled with urine, so appear as cystic structure in the pelvis, rounded in shape and internally echo-free. And when we see the urinary bladder, this means that the kidneys are working well. So between about 8 to 12 week LMB, the primitive gut migrates into the base of the umbilical cord and forms the slight bulge or physiologic mid-gut herniation. We can see bulging of the gut through the base of the umbilical cord, representing physiologic herniation, seen in about or between 8 and 12 weeks. Here is normal physiologic herniation in the base of umbilical cord up to 12 or 13 weeks. Here again, this is the cord, and in the base of the cord, we can see the bowel herniated here in the base of this cord, which is normal finding. Then structure in pregnancy, embryonic structure, gestational sac. So if we are using transvaginal sonography, we see the gestational sac, which is the first structure seen by ultrasound in early pregnancy, seen between 4.5 to 5 weeks, and 1 week later by transabdominal ultrasound, 5.5 to 6 weeks. The yolk sac appear in about 5 to 5.5 weeks if we are using transvaginal sonography, and 1 week later if we are using transabdominal sonography. So fetal ball seen in about 5.5 weeks to 6 weeks by transvaginal sonography, and 1 week later by transabdominal sonography. Fetal heartbeat at 6 weeks to and 7 weeks by transabdominal sonography. Then estimation of gestational age in the first trimester. Usually we use gestational sac size and CRL. We measure the gestational sac and also we measure the CRL or crown ram length, the length of embryo. We measure from the crown to the ram of embryo. Gestational sac size used to date pregnancy before visualization of embryo. Before we see the embryo, we can take the measurement to estimate gestational age from the gestational sac, and we measure from inner to inner. Some sac measurements are useful to predict early pregnancy failure if embryonic structure are not detected. So in the absence of detectable embryo, gestational age may be determined by measuring the size of gestational sac, including, for example, area, or we take the volume, or mean sac diameter, which is most common used. Mean sac diameter, we take 3 measurements, 1 measurement from here and 2 measurements from here. We take mean sac diameter for estimation of gestational age. This is before to see the fetal ball. So mean gestational sac diameter as equation, we take the length plus AB plus transverse over 3. So no need for these calculations. The ultrasound machine directly give you the results. So take these measurements, 3 measurements, and the machine calculates the mean sac diameter and give estimation of the gestational age. So gestational has a sac diameter of about 5 mm at 5 weeks LMB, it's about 35 days. Also, gestation age in days can be calculated by adding 30 to the mean sac diameter. Example, if the mean sac diameter is 22, add 30 to gestational age. So this means that gestation age is 52 days or 7 weeks plus 3 days. So if you are going to calculate without using machine or calculation directly, and so this technique accurate up to mean sac diameter on this time. Then CR defined as the maximum straight line. So maximum straight line of the embryo or fetus from the top or from the head to the crown. So we measure from here to here. So this is CRL or crown ram length, which is very accurate in determining the gestational age. Here how we measure the gestational age using CRL. So we measure from here to here, crown ram, from the crown to the ram, maximum straight line length for estimation of gestational age. So period to about 7.5 weeks gestation, the embryo appears as a cluster of echoes near the yolk sac or in the wall of the yolk sac. So this is before 7.5 weeks. We can see this is the gestational sac. Here is the yolk sac, and on the wall of the yolk sac we can see embryo here on the wall of the yolk sac. So it is very difficult to distinguish between the head or crown and ram. So just the echogenic structure here located on the wall of the yolk sac. So we measure from here to here. We take the length of the embryo or crown ram length, which is very accurate in determining the gestational age. So CRL measurements should never include the yolk sac or the extremities. So try to avoid measuring the yolk sac. Sometimes we may mistake this yolk sac as the head of the fetus. So try to exclude the yolk sac and the extremities from the measurement to accurately determine the gestational age. So we measure from here to here. We exclude the yolk sac and also we exclude the extremities. Here how we measure the yolk sac, CRL, sorry, this is the yolk sac, and on the wall of the yolk sac we have a small embryo. We measure from here to here. This is CRL for estimation of gestational age, and here also the yolk sac, and on the yolk sac we have this embryo. We measure the CRL from here to here, and the machine give you directly the gestational age and expected date of delivery. Again, here for estimation of gestational age, we measure the CRL, we measure from here to here. So try to avoid measuring or included the yolk sac. Here is the yolk sac, and we measure the CRL from here to here. Again, yolk sac, how to measure? We measure from here to here. Try to avoid measuring the extremities and also avoid yolk sac in the measurement. Also, you can use 3D. This is first trimester by 3D, and 3D is very helpful modality in diagnosis of congenital anomalies. So this is GE machine. And also you can diagnose also multiple pregnancy by using 3D technology. So after 12-week gestation, obtaining a good CRL measurement is generally more difficult due to increased fetal body movement. So after 12 weeks, the accuracy of CRL is not that like in early pregnancy. So we measure from here to here, and at this time the fetal movement is increased and not easy to take the CRL measurement. Then we can go for the biparietal BBD or biparietal diameter. So gestational age between 6 and 9.5 weeks can be quickly estimated from the CRL measurement using the following method. So we use CRL per centimeter plus 6.5 equal gestation age per weeks, or CRL per mm plus 24 equal gestation age per days. If you are going to calculate directly, just measure the CRL per centimeter, add 6.5. This will give you gestation age per weeks. This is up to 9.5 only. And if you measure the CRL per mm at 42, this will give you gestation age per days. So if you are going to calculate directly. Then we come to conclusion. This is early in pregnancy, before we see the gestational sac. So the endometrium is sick, homogeneously sick, uniformly sick. This is before visualization of gestational sac. Here is endometrial cavity, and here is endometrium, which is uniformly sick and hyperechoic compared to the myometrium. Here is the fundus. So this is before 4.5 weeks. The endometrium is well prepared and ready for implantation. And again, before visualization of gestational age, you see warm uterus, increased vascularity to the uterus. So this vessel representing the site of implantation, which is not yet seen by ultrasound. Then visualization of gestational sac, and the gestational sac, when the gestational sac appear, it is fundally located, eccentrically, and equilucent or echo-free rounded structure within the sick endometrium. So a sonographic feature of true pregnancy of early gestational sac. So gestational sac is fundally located, eccentrically, and well-defined with echo-free internally. Then double decidual sac sign. The endometrium is differentiated into two distinct layers. This is very reliable sonographic feature to diagnose intrauterine pregnancy. Then after that, visualization of embryo at 5.5 weeks, we see the yolk sac inside the gestational sac. The gestational sac, yes, is fundal and eccentrically. This is the endometrial cavity, this pyogenic line. Gestational sac is eccentrically, and this is the yolk sac, which is a pyogenic ring, a equilucent ring inside the gestational sac. Then after that, visualization of embryo, which appear on the wall of the yolk sac. This is the yolk sac, and on the wall of the yolk sac, we can see the embryo here, gives the diamond ring sign. And then after sac, we see the double blip sign. This is the yolk sac, and here is the amnion, and in between we see the fetal ball, double blip sign. And then we see the embryo clearly, and yolk sac is here. And then we can see the embryo, and we take the measurements for determining gestational age, either by using gestational sac diameter or taking CRL measurements. That's all. Thank you very much.
Thank you very much, Professor Dr. Abdul Rahim. Now, let's see if somebody want to ask question. Anybody having question, instead of raising hands, you can write your question in Q&A, question and answer. The plate is there. You can see the slate in which you can write questions and answers. So those who are interested to ask anything, they can write it down. We are waiting for the questions. Somebody is asking that can I get the PPT PowerPoint lecture? You will be getting recording online at YouTube channel of Afro-Asian Institute of Medical Sciences. All our free webinars are recorded, and within 2 to 3 days, we upload these lectures at our YouTube channel, which is Afro-Asian Institute of Medical Sciences. Still people are raising hands. I advise them to write their questions at question and answer slate. The first question from Ms. Maha Al-Zubair is when the placenta will be formed and when it will be the earliest visibility of placenta. Professor Ahmed?
Yeah, placenta appear in the end of first trimester, and by the early second trimester, we can see the placenta clearly. And the yolk sac firstly takes the function of the placenta till the placenta will form in the late first trimester and early second trimester.
Ms. Amani wants to ask something but raising hands. Kindly write your question in this slate. So let's see if somebody is writing anything. I have a question, Professor Dr. Ahmed, that what do you think, what are the best interventional procedures, ultrasound guided interventional procedures, which we can perform in first trimester?
Yeah, intervention procedure. Hello?
Yes, I'm asking, are there any interventional procedures for which the first trimester is the best window?
Intervention procedure for fetal abnormality or for
Yeah, for first trimester, like amniocentesis and villi sampling.
Yes, we can use amniocentesis and villi sampling, and this is for fetal congenital abnormalities.
So we usually perform villi sampling at the end of the first trimester or in the beginning of second trimester, because in early first trimester the villi or placenta
Not well formed.
are not properly formed.
Yeah.
Yeah. Thank you very much. To use 3D in first trimester.
Yes. Yes, we can use it.
Yeah, so as you saw, there were some of the images which were shown by Professor Dr. Ahmed Abdul Rahim, like the vital duct and some other images of Yolk sac. So we can use it. So better to use color Doppler or 3D whenever it is very essential. Otherwise, we need to avoid these in order to save the embryo from higher frequency. Somebody is asking, please clear me about double bleb sign and their fate. Their fate, what is their
double bleb
how they
sign.
work and how they go away.
Double bleb sign means visualization of yolk sac and amniotic membrane. We see yolk sac and amniotic membrane, and in between we see the embryo. This appear at the same time when we see the embryo. So, and after that, the amnion start to grow, and the cavity, amniotic cavity, start to expand. So earlier we can see, when we see the embryo, we see the yolk sac and small faint curved linear line around the embryo. So two blips, yolk sac and amnion, and in between we see the embryo.
Thank you. There is an attendee named Nusiba Khalafallah. She's asking, how can we measure weight of fetus in first trimester?
Fetal heart rate, we measure it by using M
No,
mode,
the
motion
weight,
and
weight of the
fetal weight.
fetus.
So no need for estimation of fetal weight in first trimester of pregnancy.
Good answer. Next question by Al Bashir Hussain is how diameter of endometrial thickness before gestational sac appearance?
Reaches
What will be the
about,
diameter at the time of implantation?
yeah, reaches about 14 mm and in some books 15 mm.
So it will be thicker as compared to the normal circumstances.
Yes.
Then is in which week we could take spectral to heartbeats in spite of M mode?
Because spectral Doppler or pulse wave Doppler has very high intensity compared with M mode, and according to many institutions and societies, recommended that we never use a pulse wave Doppler in first trimester of pregnancy because of high intensity, which may increase probability of fetal congenital anomalies.
Thank you. Mutaz Mahmood is asking, how can we calculate the things without ultrasound machine? I think asking about maybe heart rate.
Mm-hmm. I don't know, we measure the heart rate by using M mode, but I don't know how.
But he's asking, please repeat, how can we calculate without machine? So I think if you don't have machine, it will not be visible.
Yeah.
You can go to the gynecologist or obstetrician, they can measure it. Or you can put stethoscope to try to hear the cardiac activity of the fetus. If the machine is there and you can see the heart and your M mode is not working, then you can try to count the beats, which will be obviously difficult in first trimester. The next question by Dr. Ali Usman is when CRL is measured.
We measure the CRL whenever we see the embryo. We can take the CRL till 12 to 13 weeks. So the estimation of CRL to be not accurate after 13 weeks of gestation.
Iman Babikar is asking that I read an article about ultrasound guided abortion procedure. Can you tell us more about that? I think it is ultrasound guided fetocid. Abortion procedure, it can be fetocid in which they, for twin pregnancy or multiples, they try to kill one or two and to keep one safe. That is called fetocid. They put KCl in the heart of the fetus. That is not allowed or ethical in most of the Muslim countries and also in many other countries. So in abortion, which type of abortion, the question is not clear. Do you have any idea, Dr. Ahmed? He is saying, Iman, she is saying that I read an article about ultrasound guided abortion procedure.
No, I have no idea about ultrasound guided. And no, I have no
think
idea.
she wanted to ask about fetocid. I have explained it. Next is Fatima Al-Tirafi. Why we do not use pulse Doppler in first trimester?
I answered this question because pulse Doppler has very high intensity, high power. This may increase probability of biological effect.
Okay. Then is Salwa Siddiq. Can we see any anomalies in first trimester?
Yes, You can see many anomalies in first trimester.
Yes, there are a lot of anomalies we can
Yes.
see, and this is the best time to see the anomalies. The earliest visibility of anomalies on ultrasound will be possible in first trimester. Then is Ashraf Khalafullah Marghani. Ask about collection and hematoma in first trimester. Hemorrhage or hematoma, subchorionic hemorrhage.
Subchorionic hematoma. We can see clearly subchorionic hematoma, and the appearance of hematoma depends on the amount of hematoma and the time of hematoma, age of hematoma. Maybe appear hypoechoic or hypoechoic, so it depends, and also the amount of hematoma.
Then is another question: how can I know there is ectopic pregnancy in first trimester?
So in first trimester, so we should correlate the clinical presentation with ultrasound findings. So the most common sonographic findings of ectopic pregnancy is presence of complex mass in the adnexa. The patient present with amenorrhea, vaginal bleeding, pelvic pain, and there is no true gestational sac in the uterus. And when we searching in the adnexa, we can see the complex mass, or we can see gestational sac outside the uterus. And if we see the gestational sac outside the uterus, which is thick ring with high vascularity, so this is very reliable feature to diagnose an ectopic pregnancy.
Dr. Ahmed, there is another question from Bangladesh, Muhammad Shamsuzzaman. He is asking, sir, is it logical to use color Doppler to detect fetal heart rate? If no, then why? Color Doppler, I think asking about in the first trimester. As you explained that we usually don't prefer to use color Doppler in first trimester, but he's asking that can we use it only to detect the heart rate? Spectral Doppler.
I think no need for using spectral Doppler or color Doppler in first trimester, as the heart is very clearly seen by grayscale, and the heart rate is accurately can be measured by using motional mode. So no need for this modality to see the heart, as the intensity in the color Doppler and power Doppler is very high. And in ultrasound, we recommended to apply ALARA principle. ALARA principle means as low as reasonable achievable. So use lowest power and high gain whenever possible. So, and it is better to exclude the pulse Doppler and color Doppler in first trimester, unless necessary indicated.
Another attendee, Zakia, is asking, can we determine the sex of the fetus in first trimester?
Till now, according my knowledge, no.
Yeah, the earliest possible is 14 to 15 weeks.
15 weeks, yeah.
Then comes Ahmed Abdul Salam. It was a great presentation for first trimester. Could we get presentation for abnormal findings in coming days? Yes, inshallah. We will request Professor Dr. Ahmed Abdul Rahim to prepare another presentation for abnormalities in the first trimester, and we will announce it soon. You can keep on visiting our website, which is aaims.edu.pk. Secondly, we are starting some certifications with the collaboration of some of the UK universities. We are working on it. There will be also some master programs. We are working on its recognition, that which higher education will be recognizing. So it can take few months, and then inshallah we will be announcing online programs like certification programs and some of the fetal medicine programs. We also have some free webinars and courses which are coming up. So keep on visiting that. Another guy who is our extraordinary student, Dr. Tajuddin Abu Garoon, is there. So a big name in my Sudanese students, he's saying, what is the main cause of Spalding sign in case of intrauterine fetal demise? Why the bones are overlapping?
Yeah. Because the fetus is dead and the bones is uh, compress and increase edema in the fluid. This cause the bones to be bending and increase amount of fluid in this
Yes, in
area.
addition to that, the cerebrospinal fluid
Yes,
is not properly circulating, so the pressure is decreased, the external pressure is more, so it
yes.
collapses, and there will be Spalding sign. Thank you very much, Professor Dr. Ahmed Abdul Rahim. You enjoy your trip to UAE and be careful about COVID. Don't go without mask.
Yeah.
Take care of yourself. Thank you very much.
Thank you.